All right. Hello, everyone. I hope everyone is doing well and staying safe. My name is Eli Vesterfelt, and I am the Exhibit and Registration Manager here at AAID, and I just want to welcome you all to this week's Case of the Week. Our speaker today is Dr. Katherine Ferguson. Dr. Ferguson graduated from University of Florida Dental School in 1993 and went on to complete a general practice residency at Prince George's Hospital in Maryland. Dr. Ferguson maintains a private practice in Davie, Florida with her husband, and together they founded the implant training program called Implant Educators. Dr. Ferguson has taught hands-on implant placement for both cadaver workshops and also live surgery. She is a diplomate at both the DICOI and the ABOI, and she's a fellow of the AGD. Without further ado, Dr. Ferguson, welcome, and thank you for being with us today.
Oh, of course, it's my pleasure. Hope we can learn some stuff going over cases. Every time we share knowledge and share experiences with our patients, it benefits everybody. So this is the AAID Case of the Week. We're going to talk about combining perio, ortho, and bone grafting with this case. It is nice to meet everybody virtually in this weird zombie apocalypse time of everything virtual and nothing in person. That's me. We're going to talk about some decision and treatment planning. So I want to introduce you to Ruth. Ruth is an amazing individual, a lovely human. She's been in the office for between 15, almost 20 years now. And I've known her and her kids and her husband for that same amount of time. And for the past 15, almost 20 years, I have seen Ruth and her husband and her kids about every 6 months. And kind of followed the kids growing up, followed her career change from, she was on the police force for about 14, almost 15 years, and then decided to pivot and make a change and get trained as a paramedic. So she is the type of person who is there for people. She's the type of person who would just give you the shirt off of her back. Sweet, sweet person. So after working on the police force and as a paramedic for 15 years, she has decided, now that both kids are off to college, that she's going to retire and live her dream life with her 2 pensions from the police force and from the company that she was a paramedic with. So nice way to spend her last part of her 50s, 60s, 70s, and onward. So I'm a little jealous of her. So I see her all the time, and her kids and her husband, and so she comes into the office and wasn't on the schedule for anything in particular, so I wasn't really sure what she was coming in for, and then I knew she was getting the youngest off to college, but asked her what brought her in today. Is there something hurting, something broken? What can we do for you? So that's when she said that she was going to be retiring, just bought a home, her dream home, and she'd like to fix her mouth before she leaves. And we talked about things that she needed for years. Every time she'd come in, and she'd always put it off and say, well, no, I need to take care of my husband. No, I need to take care of the oldest. No, I need to take care of the youngest. And we did braces on the kids and took care of everybody but her. So like a mom, she put herself last, but now she's retiring and she's deciding it's time for her. So we'll expand on that a little bit. You're going to be moving, and how is that in retiring? How far are you going? Where are you going? When are you going? And how is that going to affect your availability to come to the office, and also your dental insurance that you have, and does that matter to you? So we talked a little bit about that. Turns out the reason I am so jealous is this is where she's going. She's going to Italia. And when is she planning on leaving? She thinks she's got plenty of time. She's starting to pack up. She's already bought the house. The house she's in now is under contract. They think they've found a buyer. So she's just putting the finishing touches on her life here in Florida. And she's ready to go in about 2 months. So that's enough time, right? Well, there are things that we have been talking about for over 2 years, and they haven't been getting better on their own. It's just been on the back burner. So 2 months is not actually enough time to do everything, but it is enough time to get started and for her to pick her most important thing that she would like. Actually, I said that wrong. It's not enough time. The 2 months is not enough time to even for her to pick her most important thing, but that's what she's going to do. We had a discussion. She decided that she'd like to get started. She'd like to pick her most important issue that she'd like to handle before she leaves. And she is willing, although she's retiring in a couple months, she is willing to stay for us to finish. So she did, and we got finished her top priority. Whenever a patient comes in and they're wanting to do anything at all, especially things that I know are going to require surgery, so we always look at the whole patient from 10,000 feet or more, big picture. And then we drill down a little bit farther to get a little closer look. And then we drill down a little bit farther still to see how healthy they are and what their cells are like. I know this is a little geeky and a little dorky, but I like to view the patients in this way because we know what's possible, not only with what they're bringing to the table in a structural fashion, but also what they bring to the table on a cellular fashion. And a really helpful thing that I learned a while ago, and I think it was Dr. Rutkowski who taught this at one of his seminars, was whenever you're going to ask a body tissue to do something for you, whether you're going to ask the blood to do something for you, soft tissue, bone, anything that you're going to ask of the body, try to look at the area, look at the environment from the point of view of the cell that you're going to be asking to work for you. So if you're going to be manipulating the soft tissue, look at the soft tissue and from the perspective of the cells. If you're going to be altering the bone, think of how bony cells react and what their environment is. And think of if you need to change that at all to make them be their best cells for you, because we ask them to do things for us, and if we can set up their environment where they can really perform their best, they will. But if we set up the environment where something is impeding them, then it's likely that we won't get the outcome that we could or that we're wanting to. And sometimes it's hard to know why we didn't get that outcome. And oftentimes it's because the cells weren't given what they needed to. So let's look from far away, just an overview. I know we talk every time she comes in and everything's always fine. She's healthy, no complaints, has her doctor's checkups, she checks off none of the boxes on the medical history. And I love this answer when you ask, do you have any allergies or take any medications? No, she doesn't have any allergies, and she doesn't hardly even take any medications, which to me means she's probably been prescribed something and takes it when she remembers or when she feels like it or when she feels she needs it. So that's when we ask a little bit more about that. And then we get the rest of the information, which is, well, yeah, for my high blood pressure, I'm on lisinopril, and my diabetes is controlled with exercise and diet. For depression, sometimes I take Zoloft, sometimes I take Wellbutrin. I go back and forth depending. And I'm supposed to take vitamin D, but I don't always remember. But I'm pretty sure my doctor told me to, but that was a while ago and I haven't had it checked in a while. And I've been trying to quit smoking, and I'm definitely going to quit smoking for this move. So this is a little bit different picture than how she was presenting herself and what she filled the medical forms out, and that's not uncommon. So sitting and talking with folks, you get more of an idea. And the reason we like to do this is if we're going to be considering surgery, we want to know what her body's going to be capable of and if we need to alter any of this. Given what she's told us, there are a couple of things we need to think about. And a last side note, and it is on the medical, and almost nobody thinks to just go ahead and tell you, but sometimes on the medical history, when they see this question, they'll remember and write something down. But not always, and in her case, it was not always. So we asked her if she took any herbals, anything from the health food store, if she enjoyed grapefruit juice often, and she said, oh, that's right, I do take St. John's wort every day, and sometimes I do like to take a grapefruit juice cleanse every few months. We're going to keep some things in mind based on what she's told us so far. So we're going to keep in mind that we're going to need to check her blood pressure and her heart rate to make sure that the lisinopril dose that she's taking is a good one for her and she's well controlled. Also, we're going to think about the pain management, post-op pain management. Since she's on lisinopril, which is an ACE inhibitor, we need to make sure that we're not going to load her up on ibuprofen. We're going to check her sugar level, since she says she's managing her diabetes with exercise and diet, but doesn't actually check her sugar. So we're going to get a good A1C measurement on her, which is going to give us a good idea of how she's been for the last 3 months. The Wellbutrin's not an SSRI, but the Zoloft is. So for loading the implants later, if we're going to consider implants, which of course we are, this is an implant talk, we're going to know that there may be a little bit higher risk of having some issues, not immediately, not at placement, not at healing, but the effects of the SSRI, the selective serotonin reuptake inhibitors may have, could be after we load the implants and the bone starts to turn over in response to the loading. So it could be a few months after we've placed the implants and we're finally loading them that we may have, we're going to look out for some problems with that. Not a huge amount. The risk for that is about the same as smokers, about twice as much. And we need to keep in mind the healing potential for smokers with the bone and also with the soft tissue. We're going to stop the St. John's wort, and we're going to look out for the grapefruit juice. Ask her not to do any of those cleanses, especially if we do any kind of sedation. The grapefruit juice can potentiate some of the sedative meds that we have. And I think I hit some, oh, here we go. Okay. There we are. Let me back up. This looks like it got stuck. Ah, here we go. Okay, so we talked about that. Then we're going to talk about the diabetes. So folks who manage their diabetes with exercise and diet sometimes do a fantastic job and sometimes don't. And we all remember why we need to make sure that the diabetes, if she is actually diabetic and not borderline, is under control, because that's going to affect her risk of infection and it's going to affect her healing capability. Turns out her A1C was under 7, which is what we look for before we do surgery. Vitamin D, we remind her to keep up with her vitamin D tabs and to get it checked with her physician before we start any kind of bony procedures. Really easy to do. Most physicians do this at checkup appointments anyway. So we know that having an adequate vitamin D level is going to help her bone heal better. And for the selective serotonin reuptake inhibitors, if she goes back and forth between the Zoloft and the Wellbutrin, we're going to find out if that's something that she does on her own, or if that's what has been prescribed to her. We're not going to take her off anything. We're just going to keep that in mind. And we remember how smoking affects healing, and there's a whole list of herbals that will either predispose the patient to increased bleeding or interact with sedative meds that we might give. So just like anything else, the really, really boring part of working folks up is the prep work, the detective work, making sure that we've looked under every rock, we've asked every question and got answers to our satisfaction. That's going to set us and the patient up for success. So let's take a look at what she's starting with. Her chief complaint is that she feels like she looks like a bulldog. She's a little class 3, same as both of her kids were, and we corrected that with the ortho. And she's always wanted to fix it, didn't have braces as a kid, is finally getting around to having them now that she's older. So that's her first number 1 priority. Number 2 priority is on her lower right, number 29, has been tender to brush for years. And we've talked about grafting, and we've talked about all kinds of options for her, and she's always put everybody first. So she's known it's a problem, just hasn't had the time to be able to address it until now. So she'd like her bite corrected, and she'd like her lower right addressed before she moves to Italy. This is what she'd like to leave with, so we're going to do our best to get her there. What we do is we take a look at all of the things that are red flags to us and all of the small portions of her case that we need to make sure we really investigate. One good thing is she doesn't have any habits that are going to get in our way. So she's not a parafunctioner, and there's nothing else that is going to slow us up, which can be just as important as adjusting things on the cellular level. So let's take a little bit closer look at what we've got. We don't have a lot of bone, and we don't have good tissue. The bone's really thin. It's a little under 3 millimeters in width. We do have the height, and that's good. But the tissue is very friable. So we know she wants her bite corrected. We know that she wants to have an area that's not tender anymore, and she'd like some teeth in the back there. So in order to get her teeth in the back, we need to put implants. In order to put implants, we need to put bone, but we also need to correct the bite, but the tissue's also not good. So what do we do first? Do we do the bone first? Add the bone and then go back and get some good tissue, or do we do the bone and then the ortho, or the ortho and then the bone, or the ortho and the soft tissue and then the ortho? I like to think of it as a journey. So we are starting off way down at the bottom of the hill, and we are trying to get all the way up to the top of the mountain. And there's more than one way to get there. We can take the easy route, or we can take the hard route. And for folks who love the excitement of post-op complications, of intraoperative complications, of late night calls on the weekend, it doesn't matter where you start. Flip a coin, pick one, doesn't matter. Just jump on in there And eventually you will get to the top, but you're going to have to claw and scrape and pick your way. So that's not my idea of a good time. And personally, I like setting things up instead of having to claw my way to the top and being surprised by intraoperative complications or post-op complications or complications that happen after we've loaded the implants. I like to cheat. I like to move the starting point real close to the finish point. I like to get to the start point as close to the finish as I possibly can. I like to take my time with moving the starting point. And then when I have a really good starting point, I like to just step over the line to the finish. That to me is the way to do it. So if you like more excitement, have at it. But I'm gonna kind of go through how I like to set things up to have it less complications and an easier time of it. So here's the site on the lower right. And you can see that she's just about class 3 anterior crossbite. She's also posterior crossbite. So she's got two things. She wasn't really aware of the posterior crossbite, nor did she care, as it didn't really affect how she looked. But we care. We care because whenever she bites down, she's banging the hell out of that second premolar, and it's not helping the case. She's got really, really thin tissue and some frenum, not a whole lot of frenum, but she's got some pull there, and the occlusion and the thin tissue isn't helping the situation. So what are we going to do first? If we fix the bone first, if we augment the bone, if we get enough bone there to put some implants in, then that is the same as starting way down the mountain. And you can, it makes your journey longer, and you're signing up for more complications. So if we add the bone without correcting the soft tissue, then it's going to be more friable tissue that we're cutting on. It's going to be thinner tissue that we're manipulating with our flaps. And it's going to be tissue that's going to be more likely to open up, the suture lines to open up, which is, of course, one of the highest complications for any surgery, the suture line opening. So it's going to be harder for us to protect ourselves from the most common complication. All right, so instead of adding the bone first, let's think about adding the soft tissue first. So if we add the soft tissue first, that will give us an easier time with adding the bone. So good. So we'll add the soft tissue first, and then we'll add the bone. Fabulous. That moves us up the mountain a little bit more. But if we add the soft tissue without correcting the bite first, then the soft tissue is going to have a harder time healing. And if you think of it from the perspective of the soft tissue cell, that tooth is inclined to the buccal enough that it's going to give some pressure on the soft tissue flap when we try to add tissue, and we're not going to get as great of a healing. And the continued banging on the tooth, because the occlusion's off, is going to make things move around, which soft tissue doesn't like when it's trying to heal. So maybe we won't start with that. Maybe we will start with fixing the occlusion first. So fixing the occlusion first will move us really, really close to the top of the mountain. That's how we get our starting point to be pretty close to our finish line. If we can fix the occlusion first, that'll make grafting easier, the soft tissue grafting easier, which in turn, the soft tissue will make, grafting the soft tissue is going to make grafting the bone easier. So if we start with the occlusion and then fix the soft tissue and then fix the bone, that's how we get rid of some of these complications and make our lives less exciting. So here's the case again. So we do just that. we put on some braces and start to fix the occlusion. And you can use, I just put on some brackets because I can put brackets on folks, and like if they agree to it, you know, half an hour we can set it up and get some brackets on and at least get them started. Also, if you like aligners, you can do it with aligners too. If you're in more of a hurry, then probably wires are the way to go, brackets and wires. But aligners work also. Either way is fine, whatever your pleasure. With the aligners, though, you need to make sure that the patients are going to wear them 24/7, except if they're eating, and if they don't, you can add more time to your treatment. Okay, so once we have corrected the bite, now it's going to be time to change the biotype or make the tissue thicker. And there's lots of articles out there supporting this. So the decision tree for grafting soft tissue is if we've got enough tissue there already and what kind of tissue we have. So if the tissue's attached, it could be keratinized, it could be not keratinized, and how much keratinized tissue do you have, if you have enough, if you don't have quite as much. And we just kind of follow this way of thinking to decide if we're going to graft or not, and what kind of graft we're going to do, whether we're going to do a free gingival graft or a connective tissue graft. So changing the biotype and grafting her is going to get us a little bit closer to the finish line. We've already corrected the bite. You can see on the lower left, and she's this Essex, upper Essex, you see her in, is actually one of her post-ortho retainers that we just modified after the free gingival graft. And the reason that we did a free gingival graft here is because if you take a measurement from the very coronal portion of the papilla on the mesial of wherever you're trying to graft, and you measure straight down 3 millimeters, and then you go to the distal, the very coronal portion, or the tip of whatever the papilla looks like, and you go down 3 millimeters, and then you draw a line between these two areas. That is a trick or a cheat that shows you in the best of all possible worlds what you can hope to gain with grafting, either connective tissue graft or free gingival graft, because that's what the bone that's underneath can support. So we knew that's the best we can get. We also knew that we want it to be really thick tissue. So, and I want it to be keratinized from the palate. I can get a thicker buildup if I do free gingival graft. So that's what we did. And you can see on her palate where the tissue was harvested. This is actually PRF membrane that does a wonderful job helping the area feel a little bit better post-op. And it also does a wonderful job helping to control the bleeding. If you don't have that, you can always use collo tape or collo plug, but we like the free gingival. For the free gingival, actually for the connective tissue graft also, the PRF works better. And this is what she looked like about a week off. That's not pus, that's just the outer layer that of sloughing cells, and that eventually we're going to wipe off after we take out the sutures, and we give it a few weeks to be really stable. We'll go and just wipe that off. But that's normal. That's what your site should look like. And we also find that when we're using the PRP and the PRF on the palate, that the soft tissue will heal over faster. And the faster you can get that to heal over, the more comfortable your patients are going to be. So things like this. Here's our sheet. This is what we knew we could get. You can see on the left what we predicted we would get, and on the right what we actually got. It's pretty close. It's a pretty good way of estimating what you can do before you do the surgery, so you know if it's worth doing the surgery or not. There are areas that you're not going to have enough bone underneath to support any grafting, and that's better to tell the patients up front that they've lost too much bone already, that you can't hike tissue up any farther. So just as a quick review, the difference between a free gingival graft and a connective tissue graft is the free gingival graft, you just make your incisions and you peel back the gingiva to expose the periosteum, and you sew your full thickness graft to this area here, and it heals. The connective tissue graft, I like to tunnel them. I find that the healing is a little quicker and it looks a little nicer. But the connective tissue graft, you'll prepare a tunnel and then you'll put the connective tissue that you harvested from the palate, or if you want to use acellular dermis, you can use that. You'll slide that underneath and then suture everything in place. Some folks get those twisted in their mind, but that's the gist of it between the two different types of surgeries.
Dr. Ferguson, we did have a question come in.
Sure.
I was asking if the patient was smoking while she was healing of FFG.
Probably. She told me she wasn't, but I don't know if I believed her. Most folks who smoke cigarettes, especially if they started in their teens, which a lot of folks did, they can swear up and down that they've stopped, and sometimes people are able to do it, but more often than not they can't. And I didn't realize just how addictive nicotine is until I was in my residency, and I had a patient, we serve the DC area, and I had a patient who had come in who was able, she was on actually for a few years before she came to see me. She was on both crack cocaine and cigarettes, nicotine cigarettes. And she decided to get cleaned up, and she got some help that she needed with addiction. And she was able to stop the crack cocaine, and she could never kick the nicotine habit. So she actually told me it was easier to quit crack than it was cigarettes. And when she said that really hit home. So people have every intention of stopping. I don't think that they're going to, and once I suspect that they are, or if they're telling me that they do, I just plan on them smoking the whole time. And I counsel them that they're at a higher risk, and we load them up with antibiotics. We do, we keep a closer eye on them because we know things can go sideways faster, and we would need to hop on it and fix it faster. And I really make sure that we use PRP and PRF on these folks, because it'll help close the soft tissue faster, and the faster it can close, the better healing that they have. So when we harvest the free gingival graft, it looks like this. We take the full thickness flap, and then we try not to leave them open because it's pretty uncomfortable. Try to put a PRF membrane, or call a tape, call a plug. This is the harvest for the connective tissue graft, which you will actually separate the top epithelial layer, and you'll go underneath and take out the connective tissue layer. And then you'll close it, and I wanted to show you this also. This is what it looks like when you've taken it out of the middle. And I like to soak it in the PRP, and if you don't have that, or if you've already spun down for your PRF and you forgot to use the different tubes, then you can put in the serum of the PRF, or if you don't have that either, then just sterile saline is okay. The main thing is this is very much alive, and it needs to be kept wet. And this is an example of one of the acellular dermises. There's a couple out there, different brands, different makers. People People have different preferences. It's just a matrix. There's no cells, but it does come from cadavers. So some folks are fine with it and some folks aren't. And so this is how it looks when you close the harvest site on the palate. So the free gingival graft, this is going to be the closure. And the connective tissue graft, because you've opened it up, taken out the middle part, and you close it back up, it's just this line that needs to heal. And the free gingival graft, this whole area needs to fill in. So you can see how the free gingival graft is a little bit more uncomfortable. One of the ways that we keep folks as comfortable as possible is we like to give them some steroids pre-op and a good antibiotic dose and good post-op analgesia. And upper Essex helps too, to keep the tongue from playing with it. So there's lots of different articles on PRP and PRF that it improves the wound healing and it's a faster surgical site closure. This actually, you said, I mentioned the Implant Educators Academy that we have. This was one of our students actually this last weekend. We usually do implant surgeries, but this student had already done all of their implant surgeries and they had a patient that they wanted to learn how to do the connective tissue grafting. And this was the student's first case. So I think they did a pretty good job. So once we have adjusted the biotype and we have nice tissue, it's time to graft the bone. And the type of bone grafting you do depends on whether you need height or not and width. And if you need just height, then you're going to want a block graft. If you need height and width, you're going to want a block graft. If you're going to need just width, you can go with a particulate graft or a block graft. So depending on what you are trying to accomplish, you pick what procedure you're going to do. Now, if you have enough bone present to have about 2 millimeters all around your implants, then you're fine. And if not, then you need to graft. And if you've got a minimum of 4, you can split it and spread it like you see here and get the implants in and graft around these gaps. If you need to use a block graft, then the ramus is the way to go. If you need a lot of height, then distraction osteogenesis is an option. There aren't very many people who do this procedure, but it is a fantastic procedure. That you section the bone away from everything except for the palatal tissue in this instance. It's the palatal tissue that gives the blood supply to this, and you have 2 plates and you have a screw, and the patient advances the screw and you move the entire block down with the palatal soft tissue, and you can get a lot more height this way than you can anywhere else. It's a little difficult. It's a little difficult to do, and it's difficult to control the forces so that you get the direction of the bone growth exactly what you want. But someone with a lot of experience, you can actually get vertical and horizontal bone growth with that. But that's not something that I have learned how to do just yet. That is still on my bucket list. Have not accomplished that yet, but this is one that I have accomplished, is the orthodontic extrusion. And the orthodontic extrusion, you can get a lot of bone height this way. The only catch is you're going to end up sacrificing some teeth. So if you've already got teeth that are going to have to go anyway, you might as well have them work for you before they go in the garbage can. This is an instance where that was the case. This is not a case that's finished. It's just an aside to show what orthodontic extrusion is like. So she comes in with this negative architecture here, not enough soft tissue, not enough bone. And so it's going to be hard to do anything at all with this. And so put her in some braces, correct her bite, move these down, do ortho on these, pull them down. I'm sure you guys have seen this before, but this is setting us up so we have lots of good soft tissue, and we're going to have lots of bone to work with later. So we'll be showing you that case later when it's finished. Before we had a deficit of soft tissue and bone, and now we've got extra. Always good. Soft tissue and bone is like money in the bank, man. You can't ever have too much. And if you ever find that you think you've got too much, it's really easy to spend and get down to the level that you want. But it's always better to have more than you need than not enough. So on this case that we're talking about today, we're not going to do any of those. What we're going to do is we're going to do grafting with particulate bone. And we're going to do this in the fashion of tenting. So here's the area after we've soft tissue grafted. And so we've corrected the bite, we've corrected the soft tissue. Now it's time to add the bone. Now we've got nice tissue. See how nice and thick this tissue is for the flat? Now if we had tried to make this flat, if we tried to pull on this tissue at all, when it was still thin before we grafted it, we would have tears, it would have a hard time healing, the blood supply to this tissue wouldn't be really great, it would not hold up to any kind of surgical trauma we're going to put it through. And because it would be so thin, it's not going to have the blood supply to feed our bone. And we're going to need it to feed our bone. So we made it nice and thick and healthy and full of capillaries. So not only can it support itself, it can now help us support the bone graft that we're putting there. So we've made the environment a nicer place for when our little bone cells look around with their little bone cell eyeballs, and when the soft tissue cells are looking around, all of those cells are much happier now. And so we can expect them to work harder for us, and we're going to ask them to. We put the tenting screws where we would like the bone to be built up, and these screws aren't sharp anywhere, and they have a domed head. So when we lay the tissue over, there's no sharp edges, because soft tissue hates anything sharp. Soft tissue likes everything nice and smooth. Bone doesn't mind a little rough. Bone likes things to hold on to, but soft tissue really doesn't. So we're going to set it up and give the cells what they want. We're also going to put some holes in the cortical bone, and that's going to give us more blood supply to the area. It's also going to increase the RAP, the regional axillary phenomenon of increased healing and turnover by increasing the metabolism of these guys right here. And we're going to do a little bit of trauma, but not too much trauma, to kind of turn them on and get them going, so they're going to be working hard when we add the bone graft. After we add the particular bone graft, we're going to cover that with a long-lasting collagen membrane, and then we're going to close it all up. Now we've fixed the bite, we've fixed the soft tissue, we've fixed the bone. We are almost at the finish line. And we have gone from wimpy little skinny bone, wimpy little skinny tissue, to nice, thick, hefty bone, nice, thick, hefty tissues. This is going to be success for us. We're going to uncover it. Of course, we need to back these screws up before we draw our osteotomies for our implants. And we're going to put the implants in. That picture's a little tilted. And when we put the implants in, we get a little bit of fracturing here. No big deal. No big deal, because we've got a lot of bone, and no big deal because the tissue that's going to cover this over is nice and thick and healthy. We're going to have a fabulous blood supply. So here we are with the implants in place, and you can see this is all graft material. That was all, we gained that with a particular tenting lateral augmentation. And you can see here, this was the original. So originally there was enough just to cover the buckle of those implants, and all of this has been built up with the graft. And there she is. She's fixed one area and she's ready to go on. She knows she needs to fix her other, the lower left, and she knows she needs something on the top right, but she is a happy camper. And to Italy she's going. She will send us postcards. So even if it looks like your case is, and I have to remind myself of this, when a case seems like it needs one thing corrected, but oh, before I correct that, I need to do something else. Oh, but before I do those two things, I need to do this other thing. That's okay. Just take it slow. Don't get frustrated. Keep up the work. Keep plugging in. Never throw in the towel. Use it to wipe up the sweat and keep going. So that's me. If anybody wants to contact me later, that's how you get in touch with me. Is there anybody? We're about 15 minutes for questions or discussion. Is there anybody that has questions for me or wants to share a case?
A question just came in the chat box. Let me see. Oh, I might butcher this word. How do you remove the periosteum with CTG?
How do you, oh, the periosteum. How do you remove the periosteum with connective tissue graft? I think the question is if you're going to harvest the connective tissue graft, so you're going to go under the outer epithelial layer and take that out. If you bring some of the periosteum from the bone with it, no big deal. You don't need to remove it. It's fine. It's full of capillaries. It's fabulous. It's going to heal in the recipient site great. It'll make the area where it was removed from and the palate a little more sore, but that's also going to heal. So there's no worries either way, and we don't have to worry about keeping the periosteum attached to it like we do when we're manipulating flaps, because we're not trying to stretch that tissue at all. The only reason we would have to worry about the periosteum if we were in an area where we were trying to advance a flap and we needed to cut it a little bit so we can get the flap to stretch. It's the periosteum that keeps it from stretching. But in this case, if you get some periosteum, or if you get all the periosteum actually on your connective tissue harvest, don't even think twice about it.
Let's see, what factors do you keep in mind while separating CTG from outer epithelium?
The biggest thing to repeat almost as a mantra in your mind while you're doing this is to take your time and don't rush. Because the minute you rush, you're going to buttonhole it and you're going to get a very, very thin outer layer, which is going to end up sloughing. And not the end of the world, but the patient is going to be more uncomfortable and it is going to take longer to heal, significantly longer to heal. And it's easier to control any bleeding that you might have if you can keep that outer layer, because you can get something in between the outer layer and the bone. You can either call it tape, call it plug, you can use the PRF membrane, whatever you want to use. It's easier to get hemostasis if the patient's a little oozy. So the biggest thing is just to take your time and don't rush.
All right, I think that's it for now. We'll give it another 30 seconds or so. If anybody's typing, we'll let them type that in. But in the meantime, while we're waiting for those, if there's any, Dr. Ferguson, thank you again for with us today and sharing this case with us. It was very informative. I learned a lot. I always learn a lot with these. I think that might be it. I don't see any more coming in. So with that, I'll sign us off. Everybody, thank you for joining us on Facebook as well. Thank you for joining us. We should have another one of these coming up in a couple weeks, so be on the lookout, and we'll see you then. Thank you so much, everybody.
Good night.
Thank you.